Acute Myocardial Infarction from Feigenbaum's Echocardiography, 7th edition. Echocardiography plays a valuable clinical role in patients with known or suspected acute myocardial infarction. It can be used to help establish the diagnosis when a regional wall motion abnormality is identified. The majority of clinical decision-making is based on visual analysis of regional wall motion. Development of a regional wall motion abnormality requires involvement of a critical mass of myocardium. Myocardial infarction below that threshold, as can be documented by sensitive enzymatic assays such as troponin, may not be associated with visible wall motion abnormalities. Detailed methods for evaluating ventricular mechanics, such as strain and strain rate, have shown increasing promise for detecting lesser degrees of ischemia or infarction. Echocardiography can provide prognostic information and also is accurate for the diagnosis of virtually all mechanical complications of myocardial infarction. This slide schematizes the normal geometry and function of the left ventricle. Note from diastole to systole, all walls thicken symmetrically accompanied by endocardial movement toward the center. This short-axis two-dimensional echocardiogram is recorded at an equivalent level to the previous schematic. Note the normal circular geometry of the left ventricle and the normal symmetric pattern of contraction. Following interruption of coronary flow, there is a well-described hierarchy of abnormalities which can be detected with echocardiography. This is referred to as the ischemic cascade. The first detectable abnormality is reduction in perfusion that can be identified with myocardial contrast echocardiography, which remains an investigational technique. The earliest functional abnormality is diastolic dysfunction, which can be detected with Doppler techniques, followed by subtle abnormalities of contractility, which may be detectable only with tissue imaging or strain analysis. Subsequently, visibly abnormal wall motion will occur in a territory consistent with the ischemic area. Typically, electrocardiographic changes occur later. With chronic interruption of flow, frank infarction and scar form. This slide schematizes the effects of ischemia in the left anterior descending territory. In diastole, there is normal circular geometry and normal wall thickness. However, in systole, the area subtended by the left anterior descending coronary artery fails to thicken. In the presence of single vessel disease, there may be compensatory hyperkinesis of the remaining walls. This short-axis view was recorded in a patient with an acute left anterior descending distribution myocardial infarction and is analogous to the previous schematic. Note in the real-time image the absence of thickening in the left anterior descending territory. Doppler tissue or speckle track imaging can be used for a highly refined assessment of myocardial performance. Abnormalities may be detected with this technique prior to the onset of visibly apparent wall motion abnormalities. This example was recorded in a patient with distal septal ischemia. Note the normal longitudinal strain at the base of the heart and the diminished and markedly delayed systolic strain in the apical segment, consistent with ongoing ischemia or infarction. As previously noted, diastolic abnormalities are ubiquitous in patients with ongoing ischemia or infarction. In this example, note the relatively normal geometry of the left ventricle and the reversed E to A ratio of 0.9, paralleled by Doppler tissue imaging. In the presence of active ischemia, diastolic dysfunction is nearly ubiquitous, and a normal E to A ratio frequently implies grade 2 diastolic dysfunction or a pseudo-normal pattern rather than normal function. Echocardiographic techniques can detect the vast majority of mechanical complications of myocardial infarction, including thrombus formation, right ventricular infarction, mitral regurgitation, both functional and related to papillary muscle rupture, acute ventricular septal defect, and pseudoaneurysm. This echocardiogram was recorded in a patient with an extensive acute anteroapical myocardial infarction in whom early thrombus formation occurred. Note the pedunculated mobile echo density in the apex of the left ventricle. A mobile pedunculated thrombus such as this confers substantial thromboembolic risk. These apical four-chamber views were recorded in a patient with a limited inferior myocardial infarction and right ventricular involvement. Note the dilation of the right atrium and a regional wall motion abnormality of the right ventricle. This was associated with mild to moderate functional tricuspid regurgitation at a relatively low velocity of 2.1 meters per second, suggesting the absence of pulmonary hypertension. This transesophageal echocardiogram was recorded in a patient with a limited inferior myocardial infarction, hypotension, and hypoxia. Note the normal function of the left ventricle, which appears to be underfilled, and a dilated hypokinetic right ventricle and marked dilation of the right atrium. Also, note the bowing of the atrial septum from right to left, suggesting substantial right atrial hypertension. The color Doppler signal confirms a significant right-to-left shunt. Injection of intravenous agitated saline confirms the presence of a significant right-to-left shunt, which was the cause of hypoxia in this patient. These parasternal images were recorded in a patient with a posterior wall myocardial infarction and functional mitral regurgitation related to apical tethering of the posterior leaflet. Notice the abnormal coaptation pattern of the leaflet, with the anterior leaflet behind the tip of the posterior and the highly eccentric mitral regurgitation jet. This apical two-chamber view was recorded in a patient with an inferior myocardial infarction and a new loud holosystolic murmur. Note the vague echo density in the left atrium immediately behind the mitral leaflet, which is suspicious for a ruptured papillary muscle head. In the color Doppler image, note the highly disorganized mitral regurgitation jet. This transesophageal echocardiogram was recorded in the same patient presented previously. Note the clearly visualized soft tissue density mass behind the anterior mitral leaflet, which represents a ruptured head of a papillary muscle. With color flow Doppler, a highly eccentric jet of moderate mitral regurgitation is clearly visualized. These subcostal images were recorded in a patient with an anteroapical myocardial infarction 72 hours previously. In standard two-dimensional imaging, note the area of thinning and dilation at the apical septum. And with color Doppler, the easily visualized septal defect with exclusive left-to-right shunting. Pseudoaneurysm is the result of a walled-off rupture of the ventricular free wall. Unlike a true aneurysm, the walls of which are comprised of dense fibrous tissue, the walls of a pseudoaneurysm are comprised of necrotic debris and thrombus, and as such, the pseudoaneurysm is prone to re-rupture, which is a potentially catastrophic further complication. A pseudoaneurysm is defined as an aneurysmal cavity exterior to the boundary of the heart, which communicates with the cavity by a narrow neck. Because the pseudoaneurysm cavity may be partially filled with thrombus, its true extent may be difficult to ascertain with echocardiography, and is often underestimated, as only the residual fluid-filled cavity is easily seen. This apical four-chamber view was recorded in an elderly patient 7 days following acute lateral wall myocardial infarction. She subsequently developed hemodynamic compromise. Note the large space adjacent to the lateral wall filled with complex echoes representing thrombus and some free-flowing blood. Because of the apical and lateral displacement of the papillary muscles, moderate to severe secondary mitral regurgitation has also occurred. A pseudoaneurysm such as this represents an emergent situation as the risk of further rupture and cardiac tamponade is exceptionally high. In conclusion, echocardiography plays valuable roles in patients with known or suspected acute myocardial infarction. It is accurate for helping to establish the diagnosis and location of myocardial infarction, provides prognostic information, and can be used to track recovery of function after interventional therapy. Furthermore, echocardiographic techniques can identify virtually all mechanical complications of myocardial infarction. Finally, there is a role for advanced imaging techniques for detailed evaluation of myocardial function in ischemic syndromes. Acute Myocardial Infarction, from Feigenbaum's Echocardiography, 7th edition.